All right. Um, not sure if you all have had this lecture yet. So it's Intro to Sensory Systems, and it's something similar to what you've learned last semester, and it's just adding on to that. So started off, you need to know what sensation is perception. So sensation is being able to consciously detect it, and perception is to interpret a sensation. Um, so basically, you need to know what's a distal stimulus. So a distal stimulus is like anything in the world, like so any noise or whatever sound or thing in the world. And proximal stimulus is whatever travels to your body and reaches to us. So like the light, pressure, sound, and um, your in your body you have a sensory organ which are nerve endings which can um, moderate the stimulus and detect it as well. So we've got a few body senses that you probably know of, and today we're going to be focusing on skin. So um, in skin, you need to know fine touch, which localizes the stimulus, and crude touch, which is a sense without a specific localization. And you've probably heard of other terms before, like muscle stretch, which is proprioception, temperature, like thermoreception, pain, object shape, balance, right? But the main thing that we're going to be learning about is regarding skin. So sensory receptors are transducers, and they're highly specific to one stimulus. So again, just different terms for different sensory organs. For vision, it's photoreceptors, and similarly, so you can read out for all of this. Okay, so this is the important part. So types of information that's transmitted, it's known as the label line principle. So basically, information from one nerve fiber is the same regardless of the original stimulus. So if something touches, like if you touch something and that triggers a pain fiber, nerve fiber, you feel pain. Okay, and nerve fibers transmit only one modality of sensation. And for location wise, the brain receives input from a receptor field. So um, it depends on how. So if you have many receptors in the same receptor field, it's all considered as one stimulus. Okay, and in terms of intensity, you've probably heard about these before in last semester, like temporal summation, where you talking about frequency. Spatial summation looks at the number of fibers and the strength of stimulus, which is weak stimuli, which um, which need to be triggered by sensitive nerve fibers, and strong stimuli can be triggered and detected by less sensitive nerve fibers. Okay, so types of information transmitted. So your nerve fibers change frequency of firing over time. So if you look at the diagrams on your right, you've got two different diagrams, right? So um, if you have receptors that are fast, rapidly adapting, um, they're basically send in an AP when first stimulated, and then they adapt. So it's a sustained stimulus, then they have an offset, then send out an AP again. Whereas if it's tonic receptor, it's slowly adapting. So you'll have slow impulses and it'll continue as long as the stimulus is present. So that's the main difference. So fast adapting, an AP is shot out immediately and it's maintained until there's a change in stimulus because it's already adapted to it. Whereas for tonic receptors, it takes time to respond to a change in whatever, perhaps temperature. And yeah, so signals travel up a spinal cord, and you've heard of your two tracks that you need to know of, your spinal thalamic and DCML, which you touched on last semester. So what you need to know now is that for your spinal thalamic, you have to break it down into lateral and medial. So lateral is for pain and temperature, and medial is for non-discriminate touch and pressure. And DCML is for proprioception. And the main difference you need to know, which you probably learned last semester, is that spinal thalamic decussates at thalamus, and the DCML decussates immediately at the spinal cord. So if you look at a diagram, it captures what you need to know. It decussates immediately at spinal thalamic, at DSML, and spinal thalamic decussates at thalamus. Did I get it wrong? Did I mix it up? Yeah, it should be the other way around. It should be spinal thalamic decussates immediately, and DSML decussates and medulla. Yeah. Okay. So yeah, you've probably seen all these different terms, but the main two tracks that you need to know is DCML and spinal thalamic. Yeah. And that's a brief intro into sensory system. Oh, one more slide, right? So, so when your signals enter your brain, they enter your back portion of your brain. So you don't really need to know your brain anatomy yet. You just need to know that there's a sensory portion known as your sensory portion of your cerebral cortex. And your primary region is your somatosensory cortex, and your secondary area is the somatic association area. And so signals are sent there usually, and that's how you're able to perceive what type of where the signal is coming from. So the signal, if perhaps if your leg touches something, the signal is sent to a specific area where your receptors for your legs are. Yeah, and that's how you're able to perceive it. Yeah. So yeah, that's it for sensory. It's not too difficult this week. Yeah.
Yep, there's just a question in the chat. I'll just get set up and you guys can answer that question. I think it was just the last question.
Yeah.
Okay.
Yeah, so spinal thalamic decussates immediately, and then DCML decussates at the thalamus. Yeah. Yeah. Thanks.
Okay, yay, we love human lifespan development. Guys, there's a lot of content. I'll try and keep it short. I'll keep it basically to really brief summaries as much as I can. I also have made comprehensive notes, so you guys can kind of just after this go and like download those, and basically that'll cover most of the content that should have been gone through in either the lecture or the workshops you're going to have. Yeah, I'll try and keep an eye on the chat, but if I don't get around to answering the questions, we can come back to them after. So I'll try and keep this short because it's psych, like no one wants to listen to me talk about psych for that long. Okay, so hopefully this got covered in your lecture this morning, but there's a few different ways that we like categorize like how we study. human development. So there's this whole, like everyone should probably like have heard about this, nature versus nurture. So basically it's kind of in the name where trying to understand whether it's genetic or hereditary influences, i.e. nature, or environmental influences, nurture, that determine the kind of person you are. Basically, consensus is that both will affect human development. And if people want to kind of figure out which one, like what's an actual environmental influence, often they'll actually conduct like identical twin studies, and that actually will be able to like help people differentiate between what's biological and environmental. Continuity versus discontinuity, kind of also in the name. Continuous, something that is continuous is smooth progression, which is like continuous. So that's something like height growth, relationship development. And something that's discontinuous would be something that has like abrupt shifts, changes, like some like really defined stages of development. So that's something like development of locomotion. So you go from rolling to crawling to walking. So it's kind of like really defined stages. You can also categorize like relationship development as discontinuous as well. So you go from being single to being in a relationship. So there are going to be things that can be both continuous, both discontinuous, depending on how like you view them. So not all of these are like one or the other. Sometimes they can be both. And lastly, we have universal versus context-specific development. So that basically is just whether there's one path or whether there's several to development. So it's like universal, kind of in the name as well, whether everyone follows the same developmental pathway, so that one pathway, or whether it's context that actually shapes development. So whether it's your development is dependent on environmental factors and interactions with other people. Okay. So once again, when we study human development, when we study anything in health basically these days, we're talking about a biopsychosocial framework. So it's about all the different kinds of factors in life that will interact together and basically like nurture development. So once again, a lot of this is kind of in the name. Biological forces, basically genetic factors that affect development. So that's all kind of like prenatal development, puberty, any predispositions you have to genetic diseases. So kind of, yeah, in your genetics, you can't really control a lot of this. Psychological forces, perceptual, cognitive, emotional, personality factors that affect development. So those are like personality traits, your cognitive development, any emotional regulation. So that's all kind of like internal stuff. Socio-cultural factors, that's kind of like your what we would call like environmental factors. So interpersonal, societal, and cultural factors are all like kind of included in this group. And then lastly, we have life cycle forces. And basically that's just how we're reflecting on how the differences in how the same event will affect people of different ages and of different groups. So you can kind of see that in the example here. So how would Alzheimer's affect someone who is in their 50s versus someone who is 85? The loss of a parent on someone who is very, very young versus someone who is, you know, maybe a teenager versus someone who's maybe in like middle-aged. So, yeah. So you have to like consider all different factors when we're studying human lifespan development. Now these are all of the developmental theories. There's a lot, very fun. Basically, all the developmental theories are basically just an organized set of ideas that is designed to explain human lifespan development. So basically all of these like fancy names that you'll eventually know, they decided, okay, you know what, I'm going to put out a theory that like this is how people develop, or like this is how humans go from A to B. Like this is my theory of how like everything works. And so I'm going to share my my big fancy pretty notes document that basically goes through all of the theories. I'm not going to cover them today. You guys can continue like reading this in your own time. There are some important ones that always get mentioned. For example, Freud. Freud is kind of like recognized as like a shit theory. Like, it's the one that gets mentioned a lot because everyone, it's kind of the one that like public knows a lot, like, oh, like Freudian, blah, 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 blah. But it's also kind of like bad because it's very, very absolute. So as you can see, if we look at the staging here, apparently a child is going to be ready for adult relationships when they reach 12 years old. So, you know, the stages kind of don't really make sense anymore. And they're also very just, yeah, very absolute, very like certain that you like once you reach, like conquer this, you reach the next stage, then you reach the next stage. So yeah, anyway. So this is what we would call something that's discontinuous, so very blocky kind of development, and universal. So Freud was like, yep, everyone's going to go through this, doesn't matter like where you grow up, where you live, what environmental factors, nothing. This is what everyone's going to go through, which as we know isn't actually the case. Another one that gets mentioned a lot is Erikson. This is basically kind of it's just like a longer version of Freud, except it's a little bit better. It's also discontinuous, also universal. So it's kind of grouped in stages, and they believe that it applies to everyone. However, there are more stages than what Freud would suggest. And basically it's kind of the theory is based on the fact that personality development is determined by interaction with both internal factors and external society. And only on the basis of knowing ourselves can we connect with others. It sounds all very philosophical, but like, yeah. So yeah, the table goes through it quite well. They will sometimes like in exam questions, they'll basically ask, like, oh, someone is, you know, however many years old, or like they're, you know, they might talk about the challenge that they're going through. What stage would they be like according to Erikson? And it's like, sometimes it's a very memory-based thing. So it's unfortunately, you do have to go through a lot of this. Then we go to learning theory. So these are the two learning theories that you need to know. Very easy. Basically, it's just how learning influences behavior. So this is continuous and but like universal, so it like applies to everyone. So Skinner's operant conditioning is one that you guys have already gone through. So that's like the positive, negative reinforcement, positive, negative punishment. And it's all kind of like in the table here. And then you've got your Bandura social learning theory. And basically all that means is that we learn by watching other people, and we are more likely to imitate the people that we admire. So that can be like, usually it's like they use parents as an example, or like, you know, grandparents, your neighbor who like you've like grown up with since like, you know, you were very, very young, and it's someone you admire, blah, blah, blah. Basically, we learn by watching other people. Then we go to the cognitive development theories. So basically how we think, how does that change over time? Key person is, I can never say the name, Piaget. Is that how you, I think it's French or something. Anyway, once again, discontinuous. So everything is in stages, and universal. Basically, what this theory goes through is that it believes that thinking develops in a universal sequence of stages, irrespective of environment. And basically, I've listed out some of the flaws here. Basically, there's no consideration of the environment, social cultural factors, which is something that nowadays, we recognize that's not exactly the way to approach healthcare. Yeah, you guys can read this. Once again, these are all the stages. And again, it's kind of like apparently you're kind of like fully developed, like you're in the formal operational period from 11 years old plus, and there's like no other staging after that. So it's like, kind of doesn't really fit. And then we have the information processing theory. Basically, it's just analyzing the specific cognitive processes when you get given a task. So how do we actually go about doing something? And basically the theory is that as we develop, we upgrade our brain, and we gain more and more advanced software and hardware, and that declines in old age. Yeah, I don't think there's, a lot of these you guys can just like read yourself. It should be pretty clear in this document. I'm not going to attempt to say the name. Sociocultural theory. The thing that I think is most important is just the zone of proximal development, just knowing that definition. So basically that's the difference between a child's performance with and without support. What else? Conceptual change theory. You guys can read that yourself as well. And then we have this, Bronfenbrenner. I always say Bronfenbrenner, but Bronfenbrenner's theory. Basically, this is ecological and systems theory. So this is the belief that development is inseparable from environmental context, which is like, yay, that's like what we kind of want. So this is continuous, and it's also context specific. So everyone is different. It's not a universal theory. So basically, a developing person is embedded in a series of complex and interacting systems, and all of those are going to influence how they actually develop throughout life. So you've got microsystem, which is their immediate environment, mesosystem, ecosystem, and macrosystem. And then lastly, the important one is Paul Bolt's lifespan perspective. And basically that just, it kind of talks about how human development is determined from like a multiplicity of factors, and you can't understand human lifespan development under a single framework, which is also, yes, that's what we kind of like believe now. So there's the 4 key features: multi-directionality, plasticity, historical context, and multiple causation. One of the more important things that they will go through is the selective optimization with compensation model. And basically it's just how people will successfully adapt to change that happens with aging. So yeah, all kind of gets, goes through this in the notes. I will go back to my slides. Basically, like, you know, they're not going to expect you to kind of just suddenly know all of these theories all at once. So it's something that you kind of just have to like keep revising and keep like making sure that you know. And I'll write up some questions for the Kahoot next time, so you guys can have a look at what an exam question will possibly look like in terms of how developmental theories get asked. Okay, newborn and childhood development. Oh my God, am I only up to this? Oh, Jesus Christ. Okay. Apparently you guys were supposed to have this, but you didn't get this, but anyway. So there are some influences on prenatal development, and these are the 4 that should have been discussed. So nutrition, because obviously when you are a fetus, the mother is the sole source of nutrition. So we expect an increase in calories, we expect weight gain during pregnancy, and a balanced diet is vital. So any inadequate maternal nutrition is linked to premature births and low birth weight. An example that they will give is a lack of folic acid increases the risk of spina bifida. Sometimes it gets asked as a question, like, oh, if the mother, you know, has a lack of folic acid in their diet when, you know, blah, 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 what is the child at risk of developing when they are born? And then like, you have to like choose A, B, C, D, E. Next is stress, because stress is linked to a release of hormones that will reduce the flow of oxygen to the fetus. It also weakens the mother's immune system, and it can cause a lot of changes in the baby when the baby is developing. Stress also encourages the risk of possible damaging behavior in mothers, for example, just like alcohol intake. And extreme stress is also linked to premature birth and low birth weight as well. Another influence, maternal age, kind of gets talked about a lot. So the older maternal age means an increasing difficulty in getting pregnant. We've also got like the one that's talked about the most, increased risk of developing Down syndrome. And then we have teratogens, and basically these are agents that cause abnormal prenatal development. And so the effect will depend on the type of organism, but there's only one organism that we're kind of talking about right now, which is fetus, like us. So the impact will change over the course of prenatal development. So these are the teratogens that will get discussed. The impact will depend on the dosage. So it's not like the minute you take like a tablet of aspirin, like the baby's going to miscarry and then like everything's going to go to shit. Like it's not like that. The impact will also change over the course of prenatal development. So that was listed here. So like if it's in weeks 0 to 2, you can get prenatal death. Weeks 3 to 7, which is the embryo, you can get major congenital abnormalities. Weeks 8 to 38, which is fetus, so that's functional defects and minor congenital abnormalities. So everything, it changes during the course of prenatal development. And the damage is not always evident at birth, so you can't always see the effects of these teratogens. So we've got 3 major categories: drugs, disease, environmental hazards. You guys can go through this. The one that they do mention a lot in the lecture is, however you say that, thalidomide, which is the sleeping tablet. It's basically, it was a sleeping tablet that was prescribed to mothers in the 1950s, and basically it causes babies to be born with deformed limbs and digits, and it was a huge big scandal, like really, really, really big deal. And yeah, you guys can like, yeah, that's the diagram. Okay, so that was prenatal development. Now we're in newborn development. Yay, babies. So when we assess newborn health, there's 2 ways we assess newborn health. So the first one is the APGAR index. This is the one it's used universally. So it's 5 categories: appearance, pulse, grimace, activity, respiration. All of this is scored from 0 to 2, and then you add them together. So 7 to 10 is good physical condition. That's what we like. 4 to 6 requires special attention, and 3 is life-threatening. So this is conducted 1 minute and 5 minutes after birth. So we just want to check that the baby's like, okay, you know. And then we've got neonatal behavioral assessment scale. So this is a scale that includes 28 behavioral items, 18 reflex items. So this is much more comprehensive than the APGAR index, and it assesses basically everything. So autonomics, body regulation, motor activity, the state of the baby, so whether they're alert, whether they're asleep, whether they're able to maintain those states, and social, how they actually interact with people. What is really important for newborn development is these newborn reflexes. They will 100% ask at least one of these newborn reflexes in the exam or like in a quiz at some point. So this is what I would really suggest having a look at. Basically, we are born with specific responses, with specific reflexes that will be triggered by specific stimuli. So these are the names of the different reflexes. And I would suggest like the responses is like, it's kind of pretty descriptive, but if you're not sure with what a reflex looks like, just like have a Google and see on YouTube what it looks like. Okay, can I skip some of this because I don't want to go on for too long. A lot of this, guys, is what you can just read yourself, I will say. Newborn growth, newborn movement development. Do you guys want me to go through this, or are you guys okay with just reading it? Because it is. Okay, I'm just going to keep going. Okay, child cognitive social development. So this is, once again, something that should be covered. I think child cognitive is an active learning, if I remember correctly. And if it is an active learning, it's going to be pretty bad. So attachment. So attachment is basically humans have like instinctively feel a sense of security, and we have a need for physical closeness. We want to be like attached to people. So this guy Bowlby's evolutionary theory is children form attachments to adults as they are more likely to survive if they do so. Usually occurs with parents, but it can be with any kind of responsive, any kind of guardian, any figure that a child is able to form an attachment with. So these are the steps towards attachment. Let me just get the chat up. Yeah, these are the steps towards attachment. So you've got pre-attachment, attachment in making, true attachment, and reciprocal relationship. So yeah, usually it's with attachment, it's usually to the mother, especially when the child is young, because yeah, they recognize the mother ever since they were like a newborn. So this is the Strange Situation Experiment by Ainsworth. And basically we've got a mother and a child in a room. A stranger will enter and the mother will leave, and then the baby's reaction is studied. So secure attachment, which occurs in 60% of kids, the child is comforted, crying stops, and then the child will begin to explore. Avoidant attachment, which occurs in 20% of kids, the child ignores the mum and turns away. 15% is the child will be upset and remain upset when the mother returns, and very difficult to console. Disorganized attachment, which is the last 5%, is where the child remains confused and very unsure of how to react. This is more worrisome because all of these other ones are kind of like what we would expect of kids. However, if they become confused, that's a little bit more worrying. So these are some factors that will influence the quality of attachment. So just parenting. So whether, you know, the parenting style of the parents. There also will be cultural variation, different like multiple attachment experiences, different like child temperament as well as the parents' own attachment history, parental stress, any mental illness, and differing like parent training programs that parents might actually attend. So consequences of attachment is basically that it's like a precursor for later relationships and later interactions as the child develops and into like later life. So the internal working model says that expectations of a relationship are derived from early caregiving experiences. So that would be like now when they're in like the attachment phase of child development. Secure attachment is thought to be due to an optimistic outlook and warm, supportive parents. And it's associated with a lot of long-term benefits. So like good self-esteem, confidence, development of positive relationships, fewer conflicts in later life. So these are some aspects, these are some features of the parent-baby interaction. So you've got mutual gaze, which is like when you like stare at the baby and the baby like looks at you and it's like really cute and they're like, they smile at you. So basically evident at birth, babies prefer to look at faces more than other patterns and shapes. It's more evident in females than males. You've got dyadic synchrony, mutual attention, effective matching, basically back and forth of vocalizations. Conversation, so there's this thing called motherly speech. Basically, it's like that baby, it's like the baby speech where you like talk to babies and like the baby talk. That's what it is. And it's very important for parents to actually talk to the baby from birth. You want to actually be interacting with the baby, which is actually very integral to development. And social referencing. Infants are actually able to read parents' emotions, contrary to popular belief. Babies are very sensitive, very, very perceptive as well. And they're able to inform opinions about how to respond to a particular situation. So there's this thing called the visual cliff experiment. So you've got this gap between the mother and the baby. If the mother frowns, the baby doesn't actually cross. However, if the mother is smiling at the baby will cross. So kind of just shows how babies will respond to situations and they're able to actually read emotions. Next, we've got play. So basically this is the timeline. So around 1 year old, you've got parallel play. So when you put two kids together, they'll play alongside each other. So they won't actually interact that much. From 15 to 18 months, you've got social play. So children would have similar activities. They'll start smiling at each other. You know, they'll start interacting a little more. And then when you've reached 2 years old, you've got cooperative play. So that's when you play roles, you interact with each other. That's when it's like, you cooperate. Wow, yay. So some gender differences that we'll see. Between 2 to 3 years old, children prefer to play with peers of their own gender. Girls are often enabling, so they support each other. Boys are often constricting, so they often very competitive. From a very young age, they're very competitive, kind of asserting their male territory or something, I don't know. But yeah, so girls supportive, boys competitive. Obviously, this isn't absolute, guys, but this is just what we have observed to be the general norm. So obviously there's going to be parental influence. So parents like to help in these activities. We like to pretend with younger kids. Often they'll be the mediator in settling any disputes that come up. And they have a very integral role in diffusing aggression and any competition that comes up. Basically, children whose parents engage with them in these play activities will end up developing to be more socially skillful. So that's what we want. You want to play with your kid, which is kind of obvious, but yeah. Next, we have attention and memory development. So what did I want to talk about in here? Not really much to talk about, guys. But basically, you've got these different definitions. So attention is when sensory information receives additional cognitive processing, very fancy scientific definition. But orienting response is the emotional and physical reactions to something that is unfamiliar. So it alerts the infant or the child or small baby toddler to new dangerous stimuli, oh wow, oh, danger up ahead. Habituation is lessened reactions to the stimulus after repeated presentations. So after you you put a kid in a situation again and again and again, it'll lessen the reaction to that stimulus. And then memory development will begin at birth or even earlier for auditory memory. So during childhood, memory will improve with age. So newborns actually show habituation to stimuli, but the memories last only for a few seconds. From 5 months, newborns will be able to form memory of faces that actually last up to 3 months. By 2 years old, infants can form a complex and relatively durable memory. And basically it just increases with age. And obviously it decreases with old age as well. And then we have cognitive development. So this is, I put in the developmental theories document. Basically, there are other theories that will be covered in the active learning, but Carey's conceptual change theory is one of the most important. Basically, it's emphasizes the role of experience in cognitive development. So full cognitive potential is attained at around 7 to 9 years old, and it's domain specific rather than domain general knowledge. So before age 6 to 7, so you have intuitive psychology, is the children's framework for understanding bodily processes. So we always like refer to how children understand things with like how they understand biological processes. So causality is based on intentions, desires, and beliefs rather than the actual internal biological processes. For example, your tummy rumbles when you are hungry because it wants to eat. However, after age 6 or 7, we have mechanistic explanations are more common, and children are actually able to start to differentiate between biological phenomena from like psychological ones. So they're actually able to perceive the inside of living things as being composed of like internal parts, and they're able to actually like start understanding internal biological processes. And then lastly, they'll cover how children understand death. So if we look at Piaget so examines the subcomponents of death. So if we look at pre-operational, if the child is in a pre-operational stage, they'll think death is reversible. It's characterized by being still, eyes closed, or just like departing. If they're in the concrete operational period, so they'll think it's universal, irreversible, and it's caused by elements outside the body. So guns, germs, accidents, blah, blah. And if they're in the formal operational period, they'll recognize that death is inevitable, universal, and it's basically a cessation of bodily function. However, like Piaget, like if we look back at the developmental theory, like Piaget isn't, where is it? Like apparently they're in the formal operational period from 11-year-old onwards. Like if you know, maybe, but like sometimes the stages don't really like make sense. But anyway. Okay, so new research shows that the understanding of subcomponents of death is influenced by sociocultural and environmental factors. Wow, what a surprise. So basically different factors, different exposures that the child actually goes through from early life to like as they develop will affect how well or how early they actually understand the concept of death. And then lastly, so there was this study that was done by very aptly named guy, Slaughter, in 2005. Basically, children are likely to understand death differently to adults because they don't understand death as a biological event, which makes sense. So preschool children largely think about death as departure or just like going to sleep. So the clinical implications of this is that we want to avoid inadvertently like fueling this misconception. You don't want to like say, oh yeah, she's just gone to sleep, you know, she's just like, you know, she's in, you know, at peace now, blah, blah, blah. Like you want to kind of avoid keeping this going. But you also want to avoid giving a biological explanation when you know that it won't be understood. So if you like a 5-year-old comes up to you and goes, what's going on? You don't want to say, oh yes, like her heart has stopped. Like the blood isn't pumping around her body anymore. Like, you know, like you don't want to do that. So kind of like common sense as well. It depending on how old the kid is, you'll give a different explanation. And yeah, that is basically all of your week's worth of HLSD covered. And so what I've done is I've put newborn and child development also up in the notes so you guys can download these slides or these notes easier. I think I did want to add something to the child's understanding of death just a little more. I think there was something that wasn't covered, that was covered in the active learning, but I didn't cover it in my slides because it wasn't that important, but I'll add it into the notes for you guys just as extra information. But yeah, that's all from me. Any questions before I head off and drill anatomy into my brain? Cool.
Sweet. There's like a bunch of stuff to do. We still got like David's skeletal muscle Zoe's anatomy, and we still got the Kahoot left. Did anyone want to go through anything in particular?
Also, quick clarification for the spinal cord stuff.
Yeah, true.
Like, yeah. Yeah, I'll quickly talk through it. So whoever mentioned it earlier. So for this slide, can you see that?
Yep.
Yeah. So for this slide here, whoever messaged or commented in the chat a bit earlier, you're right. So the spinal thalamic tract, that one decusates immediately. So this is actually probably the best diagram, the clearest diagram. So if you have something coming in, the spinal, both DCML and spinal thalamic, they're both sensory, and sensory come through the dorsal horn. So you're correct, whoever said that. So it comes in through the dorsal horn, and then it synapses immediately. So that's what this thing represents. And then it decusates. So it crosses over immediately, and then it synapses again in the thalamus, and then goes up to the cerebral cortex. And whereas the DCML, so it enters, it synapses first, and then it travels up to the medulla, and then once it has synapsed again, so it synapses once, then it synapses again, and then after it synapses the second time, then it crosses over or decusates, and then it goes up to the thalamus where it synapses again, and then goes to the cerebral cortex. So the main types of questions you'll actually get regarding this topic, you'll basically only really ever get one type of question is, let's say you have some kind of lesion or some kind of injury to the left or the right spinothalamic tract or the left or the right DCML pathway. So for example, if you have a lesion of the spinothalamic pathway at like up here, so a spinothalamic pathway, what kind of sensation will you lose? So let's say your lesion was on the right hand side, that means you'd probably lose if it was a lateral spinothalamic tract, because we know the lateral spinothalamic tract transmits pain and temperature. So if your right side was injured, you wouldn't be able to feel pain and temperature on the left side of your body below that lesion. So if you're still confused about this, like have a read through the slides and especially look at this diagram multiple times and just try come up with different scenarios. So what happens if I, injure this side or the other side, like what will actually happen? And yeah, don't really worry about the synapsing too much because it's not really relevant in first year. You just really need to care about when it crosses over. Yeah, that's all I have to say about this.
So, yeah, so did anyone have any preferences on like what we cover next? Like if we were to pick from skeletal muscle anatomy and the Kahoot, what do people want to do? Because we've been going for like 50 minutes or so now, or like in 40 minutes. Kahoot. Also, how's asynchronous anatomy so far for everyone? How are you guys finding it? I think we're going to do Kahoot, unless anyone else says anything. Guys, how's asynchronous anatomy? Please let me know. With this Kahoot, I actually looked through some of like the past exam papers for a lot of the anatomy questions. So some of these, they're going to be like buzzword heavy. And these are the things that'll get you like as soon as you see that buzzword, you just want to select the answer. Yeah, I think I went with like the buzzwordy questions rather than like the more high yield things rather than the small little details that you probably shouldn't worry too much about at this point. Okay. They're not playing. Oh, wait. I don't know if you guys can hear that. Can you hear that? Okay. Is it too loud? No, it's good. Okay. What are these names? What the heck? Okay, we'll wait till we get like. Just wait a little bit. I'm gonna start. And then we'll go through it. Good job, everyone. So temporality is the most important because something can't cause it if it doesn't come before it. If it happens after or at the same time, then it can't cause it, right? Sure, the other ones might be valid, but they don't always have to be that. Temporality is the only one that must always be there. So, this is a bit of a weird question. The reason why we say that people with no mental illness and low well-being are worst off, is because if you don't have a mental illness, then you probably won't show any symptoms, right? And if you don't show any symptoms, that means that you're going to be kind of overlooked, which is a bad thing. You don't want to overlook anyone. Whereas if you have a mental illness, which is green, and low well-being, chances are is that you're going to be seeking help, and people are also going to be trying to seek out. People are going to try to help you. So therefore, you're actually doing better than those who aren't getting any help and aren't being looked at. So it's a bit of a weird thing. On the slides, there's like one of those axes where you have wellness on one axis and then mental health on the other axis. And I think you can gather the different combinations of wellness and mental health, mental illness from that compass. Good job, everyone. So the answer for this one is the clavicle, or your, what's this called? Your collarbone. Yeah, your collarbone. And your divisions of the brachial plexus are typically found here. So divisions referring to anterior and posterior of each trunk. Pec minor is not quite. Pec minor is a touch more distal, I believe, and that's the muscle. So we'll be talking about the bony landmark, which is the clavicle for the divisions. And the first rib, very similar to the pec minor and pec major. Yeah, good job. Oh, well, a bit of a mixed result here. Yeah, so the terminology can be a bit confusing here, but you've got to remember what refers to medial and what refers to lateral, and then think about your different thirds. So with our clavicle, they're most frequently fractured essentially at the bend, because it's kind of a bendy bone instead of just a straight bone. And this bend occurs 2/3, it occurs between the junction of your lateral 1/3 and the medial 2/3. So it doesn't occur halfway through because that's not where the bend is, but it's actually with the lateral 1/3 and then the medial 2/3. Yep, so that's a little bit of a landmark to know about where a fractured clavicle is most likely to occur. Yep, and then your acromion is, yeah, a bit further off. Good, so flexing the elbow and extending the elbow for the anterior and posterior compartments. Internally and externally rotate, they are going to do with, that's to do with our, oh crap, what's it called? Your rotator cuff muscles, which we have a couple of questions on later on. And then we'll go through those in more detail when we get to those questions. This is like a double. Okay, so this is a very buzzwordy question, and it refers to the long thoracic nerve. The long thoracic nerve innervates the serratus anterior, which is kind of a muscle that is attached to your scapula, as well as your like anterior and lateral rib wall, and it essentially functions. It functions to. Sorry, there's a truck outside. It functions to pull your scapula like against your rib wall. So if you damage the nerve, your scapula is kind of going to swing out. And that's called winging of the scapula. Typically damaged during like a mastectomy or removing, or like like a knife to the chest, I think. So long thoracic nerve and winging of the scapula is something that you should really be trying to pair together. And that's a really buzzwordy question that they'll probably ask you in one of your PACA quizzes next week. Yeah, so once again, auxiliary nerve and the regimental or sergeant's patch, very commonly referred to. So the auxiliary nerve, we're referring to the sensory innervation, and your regimental or sergeant's patch is it's essentially the area of skin on your shoulder where if you were in the army, you would get, I don't know, like patches or something like that, like awards, I think. And that's like around your shoulder region on the outside there. So that's called the regimental or sergeant's patch. Good, so it's neither sufficient or necessary. And the reason for that is because even though you smoke, it doesn't guarantee that you will develop lung cancer. And the same goes, if you develop lung cancer, it doesn't mean that you definitely smoked. So therefore it's neither sufficient or necessary. The reason why it's not red is because although you may think it's sufficient, like smoking could increase your risk for lung cancer, you still probably need some other factors for you to develop lung cancer, perhaps such as a family history or certain stresses or environmental things. Yeah, there's really such a huge range. So it's neither sufficient or necessary for lung cancer.
Yeah, the question is causation, right? It's not just correlation. Like you can't just say X will link to Y. Like smoking isn't like you will greatly increase the risk, and so correlation will go through the roof. But it's hard to say causation alone.
It's like you see these like 100-year-olds who say the key to living for 100 years is smoking. Once again, correlation, not causation. So I'm glad that most people picked the ventral route, which is for your motor innervation, whereas your dorsal route is for your sensory innervation. Yeah, and then it's grey matter, which exists kind of on the outside of your spinal cord, whereas the white matter exists kind of on the inside and in the core. Yeah, so same Dave is the acronym we use. So sensory refers to the afferent signals and motor refers to the efferent. And then dorsal refers to afferent or sensory. And then ventral refers to efferent or motor. So same Dave kind of helps you to link up all these three terms: sensory, afferent, and dorsal, and then motor, efferent, and ventral. Yep, so rate coding is a way we increase the force because since every action potential is all or none, so either way, it's either going to be 100% of its strength or none of it. There's no in between. You can't get a strong action potential versus a weak action potential. So therefore, the only way to conduct kind of information about how strongly we want to contract the muscle is through how frequently we send action potentials through that neuron. And that's called rate coding. The other ones just don't exist, despite strength coding sounding pretty enticing, as well as force coding. The other way, other than rate coding, is if you get multiple neurons going to the same muscle and all of them send an action potential through, that'll also increase the force of the muscle. Yeah, so remember that your subscapularis muscle is part of your rotator cuff. I'm not sure if there's a question on it later about these actions, so I'm not going to talk about it. But remember that your subscapularis is located on the inside of your scapula. So it's basically the most anterior or the most front-facing rotator cuff. So therefore your scapula is actually located posteriorly to the subscapularis muscle. So it can't be ribs because the ribs would be anterior. Pec minor is on the opposite side of the rib cage, and same with pec major, also on the opposite side of the rib cage. On the front. Yeah. Multi-select. So your rotator cuff muscles. So we have 4 rotator cuffs. The supraspinatus, your subscapularis, teres minor, and infraspinatus. So if you look at a diagram of a scapula, you have the supraspinous fossa, and that's kind of on the top of your shoulder here. And therefore, if you have a muscle up here, when it contracts, it's going to abduct your shoulder for the first couple of degrees. As we talked about in the last question, your subscapularis is located on the anterior portion of your scapula, between your scapula and your rib cage. And therefore that's going to be to do with internal rotation or medial rotation. Whereas your teres minor and your infraspinatus is located on the infraspinous fossa, whereas your teres minor goes from like your inferior angle to like your humerus somewhere. And that's located on the posterior side. So if it runs across the posterior side or the back of your humerus and your scapula, when it contracts, it's going to help externally rotate your shoulder or laterally rotate your shoulder. So teres minor and infraspinatus are your 2 muscles that assist with external rotation. Oh, nice. That's actually better than I thought. Good. So your musculocutaneous one, like I always try to imagine the diagram, and that's the one at the very, very top. That one typically comes off the posterior cord. Oh, right. That one, it doesn't come off it. It comes off the anterior, I think. Or your medial, sorry. Or lateral, oh crap. Anyway, it's your axillary and your radial nerve that come off the posterior cord of the brachial plexus. The reason I asked this was, I think one of the nat tutors asked everyone, and they got, they allowed everyone to like have a go at it, and they got to do something in dissection. It's been a year, so Yeah, so thanks, sorry. So the ulna comes from the medial cord, and then I'm guessing the musculocutaneous comes from the lateral cord. But don't take that for a fact, just look at the diagram, and then you can follow through the different cords and what nerves they eventually lead to. But good job to everyone who got the radial and axillary nerve. So it's all about mobility for your shoulder. You have such a huge range of motion that comes at a cost. Because if you need to move something more, that means you have less attachments, less surrounding ligaments and less surrounding bones, and therefore it's less stable. That's why people like absolutely wreck their shoulders and get them dislocated all the time. You'll compare this later to your hip joint, where your hip joint is mostly for stability since it's all weight bearing, and therefore it's not as mobile. Yep, so that's a good comparison to make between your shoulder joint and your hip joint. So anterior compartment, we can remember that it's made of three muscles. Three muscles. So your biceps brachii, which is like your main one that people like to flex, your brachialis, which is a bit deeper, and then your coracobrachialis, which is a bit of a tiny muscle, honestly. And it kind of runs between your coracoid process on your scapula, and it runs all the way down into your humerus, I believe. Humerus or one of your forearm bones. And it's a really slim muscle, but it's important because the musculocutaneous nerve pierces through it. Not sure why it's important to know, but it was an exam question, so I chucked it in there. So it's a coracobrachialis muscle. So as David said, like in the anterior compartment, the way to remember it is BBC, and that's all the musculocutaneous innervation, BBC. So brachialis, biceps brachialis, and the coracobrachialis. And then Zoe's put some muscles that attach to the coracoid process in the chat. Hopefully this Nice, good. So your BBC is your musculocutaneous nerve. That's, for some reason, it's like the most ridiculously helpful acronym you can learn for upper limb. Brachioradialis is a muscle. It just exists more in the forearm. And it's more to do with your supination and pronation, I think. So BBC is the way to go for the musculocutaneous nerve. And all of these are really to do with elbow flexion. So you kind of want to think where your scapula is. Your scapula, as we were talking about before, overlies your rib cage. And if it overlies your rib cage, it's going to be in the thoracic region for your vertebra. So therefore we can rule out blue, although it has the same numbers. And yeah, so the spine of the scapula, remember, it separates the supraspinous fossa from the infraspinous fossa, and that's found at the T3 level. And then the inferior angle is found at the T7 level. I chucked in T2 for the spine of the scapula as a potential option because T2 is the vertebral level at which you find the superior angle of the scapula. So it's just slightly above. So the correct answer is T3 and T7 for the spine and inferior angle, respectively. The reason this is useful is for when you do your clin skills exam for the MSK shoulder joint, is you can palpate your spine of the scapula fairly easily, and that can help orientate yourself as to which vertebral level you're around. And same with the inferior angle. Probably a bit more difficult to palpate, but you can palpate it. Oh, 15 correct answers in a row. Jeez, that's crazy. Another buzzword question. So remember that your axillary nerve is somewhat of a special nerve. It runs behind, like posterior to the humerus. So therefore, if you get a posterior shoulder dislocation, it could kind of move it and rip it and cause some pathologies there. The other nerves are more anterior, so they won't really get affected there. BMC innervated muscular cutaneous are exclusive. Yeah, read the chat. Whoever's coming first right now is like absolutely killing it. Don't know how you do that. So sternofemoral doesn't really make sense because you have the humerus, which is your arm bone, and your sternum, which is your center chest piece, and therefore they can't really articulate with each other. Yep, the others exist. And the name suggests it, which is useful. Then last question. Well. Cool. Glad to hear it. So yeah, I think hopefully that quiz kind of helps clear up some buzzwords and kind of things to look out for your anatomy questions. So like I think I had a really, really quick skim through, like looked at a couple seconds of your upper limb lecture, and yeah, yikes, now I understand why you guys were like drowning last week. Yeah, that was really detailed. Like, it was a bit ridiculous, to be honest. So good job, everyone. I'll show you who won. Good job to everyone here. And I'll be putting up these questions on the drive later with the answers. So hopefully everybody, good job to who first. 99 is absolutely insane. Yeah, good job for everyone. Very good. Do you want to present?
Cool. Okay. I'll just share screen.
Yeah, we're going through skeletal muscle.
Yeah. All right, I'll try and like do this as quick as I can since everyone's probably dead. All right, is this working? It's working, right? Yep, okay.
Yep.
Cool. Skeletal muscle. Wait, I don't want to share that. I want to present it. Okay, cool. So skeletal muscle, essentially just kind of need to get the basics of it. Like Michael Lung's lecture was pretty short. It was like a 34-page lecture. He covers some main ideas, and then last year, at least for us, he like made you kind of discuss it like with the person next to you during the lectures. It was kind of strange. So I'll just cover on the main points and what you kind of really actually need to know about what skeletal muscle function is and what it kind of does, and the kind of excitation, contraction coupling, as well as like how the depolarization kind of system works. All right, so, all right, basic unit of the muscle. Like we need to understand the basic functional structure of the muscle. So firstly, we have this band, right? Like these basic units, just like how cells are like the smallest unit of life, as we say, sarcomeres are the smallest unit of muscles. So the way to remember all of this, like you'll probably get like this electron microscope image of the sarcomere, and then you'll be like, all right, label this part. It's not as hard as you think. Just think of M standing for middle, so it's right in the middle. Z, do you guys see, like if you see here, right, like it's like that, got that Z shape. Oh no, oh no. Yep, so we've got that Z-shaped squiggly up lines around here. So that kind of illustrates it's like the Z band. And between the two Z bands, what do we have? Well, between the two Z bands, we have one sarcomere. All right. Okay, so sarcomere, this is like what I was talking about before. So between two Z bands here, we have one sarcomere. Think about like Z being like the end of the alphabet, you know, so it's like the two ends together makes one. So that's one sarcomere. And what the A band is essentially is where all like the myosin is, which is a little bit confusing at times since it's not A for actin, but it's mainly where the myosin is, and there is a bit of crossover with the actin and myosin. You'll just need to draw this out a few times and it will just kind of help you understand like where everything is. Don't worry too much about Tidin. He has like one slide on this. Tidin essentially is just like a connective supporting structure to ensure everything's like in place, and it kind of looks like this slinky, right? And that's kind of the point of it too. It's holding the the myosin in place. All right, so ultrastructure of the myofibril, right? What does ultrastructure mean? It just means it's like the very minuscule structure of the different components of a very small structure already. So ultrastructure wise, a muscle is just made up of individual muscle fibers, and longitudinally, right? So it's stretched out, there are bundles of myofibrils. So this is what we just looked at. So myofibril can be divided into individual sarcomeres, and a sarcomere is indicated between two Z lines. It's composed of filaments called bands. So bands are within filaments, and contractions cause no change in the length of the active band and contraction causes, yeah, so no change in the length of the active band and shortening of the I band and shortening of the H zone. So just think of no shortening of the actual actin, but it's actually shortening of the I band and the H zone. So if we go back, what does this kind of looks like? So it just means that the A band doesn't actually shorten. It's just that everything else comes together. Think of band like as a zone, and everything else just kind of comes together. Okay. So I band is light filaments, A band is thick filaments. And what does that actually mean? I'll go into that in a sec. H zone is the central region, and M is the middle line. So should have it next slide. So sorry. Yeah. So actin here is your light filament, and myosin here is your thick filament, and this is like what this slide is referring to in terms of light and thick filaments. Okay. All right, so ultrastructure of a cycloplasmic reticulum. This is kind of how all your depolarization and how all of these things kind of actually work and gets put together. So we have these few components, right? First, we have this thing called the T-tubule, terminal cisternae, cyclolemma, and myofibrils. What we need to kind of think of is that the T-tubules are essentially this, is the elongation or connection right of the cytoplasmic membrane anyways, and cyclolemma being the membrane itself. And myofibrils is what we talked about before, right? You can see all the Z lines here, and this is terminal cisternae are just spaces in which spaces within this entire cytoplasmic reticulum. Okay, so go into a bit more detail about what they actually are. So T-tubules, membranes are just extensions of that surface membrane, and therefore the interiors of the T-tubules are actually part of the extracellular compartment. So that's pretty important to remember when we're looking at the depolarization and calcium, how calcium moves later on. Yep, so that means that signals can actually travel down the actual muscles. And terminal cisternae, so basically it just means most of the skeletal muscle is actually stored in this terminal cisternae. Terminal, think of it like the train terminal, right? Like you store the trains, the trams and stuff in this terminal area. Okay, so now this is pretty important. This is probably one of the more high yield things when it comes to understanding muscles and how they actually work. Why do I say it's important? Because it's really important when we're not just thinking about like skeletal muscle, but when you're later on doing cardiac muscle, this is like all the stuff that you will be needing to understand. Like, so if you don't fully understand excitation, contraction, coupling just yet, like don't worry too much. You'll be covering it again once we get to cardio. So proteins of the sarcomere, there's a few parts. So let's look through this, right? So we have the thin filament. Yeah, okay. So essentially we have this myosin thing, right? Like we have, it's like a hook, right? There's a hook head here. It wants to hook onto the actin, but there's so many things kind of in the way. So the troponin here is like the lock, and we've got the tropomyosin here, which is kind of like the door. So how do we actually open this troponin? Well, the calcium needs to bind onto the troponin, and that in turn will kind of click, and it will kind of switch, which will kind of push over the tropomyosin, revealing all of these myosin binding sites, right? So this myosin can then attach onwards, and it will go back to its normal shape once ATP has been attached to it. I've got a bit of a story time for you guys. So when it comes to how to remember this. So, yep, so this is what I just was talking about before. So actin is thin, myosin is thick, tropomyosin will block the myosin binding sites on the actin. Troponin is a switch on or lever on the tropomyosin, and myosin is the cross bridge actually pulling forward. All right, so story time. So I've got a son, you know, like his name's my son. So myosin rhymes with Tyson. It's like myosin, right? So he wanted to go get his actin switch 360 behind a locked door, right? So myosin wants to go to touch on the actin. He needs to go in and hook up to the actin. But how does he actually get through the door, right? The door's blocking him. The door is meant to trip my son up. So that kind of sounds like tropomyosin, right? So it's tripping him up. So then he realizes there is a lock, and it's made out of ninja troopers. So troponin, ninja troopers, whatever. Yep, so it's made out of ninja troopers, and it's just chilling. But suddenly, my son, right, he realizes that he can pull a key onto it called calcium. Calcium opens up the lock opens up the door, and now he can get to his actin. So a bit of like disclaimer, I guess. Myosin doesn't actually have calcium. Calcium comes from two different places. That's what we call the calcium-calcium coupling. So when it comes to calcium, it can come from extracellular to help DHP later, which I'll go into it, don't worry about it. But just to know that myosin itself doesn't actually have calcium, it's more so from other places. So myosin has ATPase activity, which means it splits the ATP into giving myosin this high energy into ADP, so adenosine diphosphate, and PI, which is I think it's called
It's inorganic phosphate.
yeah, like it's just like it's a phosphate that actually gives the swing movement of the myosin cockhead to actually push it forward. So once myosin binds to actin, the chemical energy is actually transferred into mechanical energy, right? So you just think it's like locked on, and now you can just push it forward. Yeah, so the inorganic phosphate is actually what pushes it forward and not the ATP. The ATP actually puts it back into a resting position. And just remember that we're also talking about striated muscle for now. Smooth muscle has a little bit more different things to it. It's not as like this. Yeah. Okay, so excitation, contraction, coupling. This is really important. Michael just tells you to, like, when you guys have an active learning or have activities, he will tell you, like, you got to figure out these steps. And it is really important. So firstly, we start off with skeletal muscle. Action potential is initiated in the neuromuscular junction, right? So this kind of depolarization occurs, and this action potential then travels down the T-tubule. So down T-tubule, and then this voltage change causes the
Pyridine.
Pyridine, yeah. So dihydropyridine receptor to stop blocking the ryanodine receptors. So this is the gate to ryanodine receptors, which are just calcium channels. So it wants to keep releasing calcium channels, but DHP stops it, and that doesn't mean dragon hot pot. Yep. So cytosol calcium is then released if this ryanodine receptor is allowed to release them, right? So calcium is released, leading to more ryanodines open up, which means there's an even more increased calcium ion released into the muscle, into the sarcomere. Wait, yeah. So, and then once that happens, this kind of creates this wave. So more and more calcium happens, and then insert here for the actin myosin contraction, which is kind of what we mentioned briefly just before. And this leads to calcium pumped back into the sarcoplasmic reticulum by calcium ATPase called SERCA. So just think of SERCA as a pump that requires ATP that gets all the calcium back into the sarcoplasmic reticulum. So the muscle then just relaxes and chills out now that the calcium levels is lower and ATP is needed to dissociate the actin from the myosin, so to go back to resting state. And what does rigor mortis mean, right? It's a kind of an application of all of these ideas. So when someone dies, the myosin is stuck to the actin. So remember what we said about how ATP is needed to create the unlocking, like getting the myosin off the actin. So if we don't, if someone has passed away, then they're not producing any more ATP. So therefore, what does that mean? It means that the ATP is no longer, there is no more ATP for the myosin to become unstuck now, right? But then the question that is going to be in our minds is, okay, so then why do people eventually, like get soft in quotation marks? Well, what that means is the protein is slowly to break down, protein degradation, then that eventually leads to the muscle, the actin, the myosin, everything just kind of degenerating. This is just like an image I found on Google about the steps in excitation and contraction coupling. So starting off with the action potential, voltage gate channel open up, calcium induces, so that the external calcium that goes through the T-tubule here goes into the cell, and then that actually makes the DHP open up, allowing more calcium to exit into the actual sarcomere. So then what does this actually mean? It means that it's like the sum, what we call the calcium-calcium coupling. It needs calcium to actually release more calcium. And calcium ions bind to troponin, and that's like where we talked about before, about the actin-myosin push. And calcium is just pushed back into the sarcoplasmic reticulum for storage through circa. It doesn't show on this diagram, but circa is like what I was talking about before. And don't worry too much about the sodium potassium ATPase. Just mainly focus on kind of this part of things. All right. What do I have here? So calcium ions are going to be released into the presynaptic neuron by the action potential. And this also leads to the release of ACH. So ACH is acetylcholine, and that leads to muscle depolarization at the motor end plate. And the entire muscle then gets a signal, right? And then it leads to the electroactivity actually spreading, because one leads to the other, and so on. So acetylcholine activates DHP receptors. Just a brief note that DHP receptors are a way that we it's a type of calcium channel blocker that we will later see in cardiac pharmacology, where we will need to use that to kind of decrease blood pressure. And that kind of in turn leads to the ryanodine receptors, that's a typo, to release calcium from the sarcoplasmic reticulum. And this is, I've kind of gone through this like a few times, and I think it's just important to kind of hammer in the idea of how calcium actually plays a role in it alongside action potential and the DHP and ryanodine receptors. So cross-bridge cycling, it's just important to note that calcium mentioned before is coming from two parts. One is outside, one is inside. Inside being the cystosolic, meaning it was inside the cytosol already. And this kind of cycle between the myosin and cross-bridge is what we talked about before. I've already talked about the side, like I think I've hammered on enough about it, about DHP and ryanodine. Okay, length tension relationship. Michael Lung didn't really talk too much about it, but it is just important to understand the sliding filament theory and explaining the length, explains the kind of length tension relationship. So optimal length, right? Like it's just right so that actin and myosin can have the max contact area, and that leads to the most force that you can kind of generate. Whereas maximum length, there is no overlap, so what's the point of that? And the minimum length is like there's not enough crossover, so there's not enough tension produced, so you can't actually do anything with, you don't have enough potential. And this is the kind of diagram, this is just directly from your lecture, and this entire diagram kind of illustrates the idea of that. Okay, so isotonic and isometric contractions. Iso just means the same. Isotonic, tone, right? Tonic, tension. So muscle changes while maintaining constant tension. So this is like kind of your bicep curls. If you don't, that's why people don't go all the way down, because then you release all the tension that you have. That's why it's just before you're fully extended and you come back up. Whereas in isometric, think of it as like you're holding a grocery bag and you kind of can't, you're not lifting it, you're not doing anything yet, but the tension is still developed, but the length hasn't changed. Okay, so concentric, eccentric motion. So concentric just means towards itself. Towards itself means it will be shortening of the muscle, whereas eccentric is away from yourself, so lengthening of the muscle. So E is like exit, so it's like away, or E is like eccentric, it's like kind of weird, which is like also go away. All right, that was actually faster than I thought. Yeah.
Yeah, that brings us, that's everything, basically. So cool, thanks for sticking around, guys. Yeah, we'll check this up on YouTube and then put up the Kahoot questions as well. Otherwise, message us if you have any questions. And yeah, we'll try to help you guys out.